Hello and welcome to another class on infectious diseases. The topic for today's discussion is going to be pus in the thorax. So, as you know, this is going to be a case based discussion. A lot of it is going to be theory, but they'll be centered around real life cases that I have recently come across in my practice. And it's very likely that if you're working in any secondary or tertiary level of healthcare center, you're likely to come across such cases in your practice as well. So let's take a look at a very regular presentation. So 45-year-old female farmer, she's from rural Andhra Pradesh, and she's presenting with a 20-day history of fever and cough with expectoration. So it's more like a subacute presentation. And the fever is initially it was low grade and now it's a high grade fever, right? Up to 103 degrees Fahrenheit with rigors and night sweats. There was initially a dry cough which has now turned purulent, and there is mild blood streaking as well. No other localizing symptoms. On examination appears ill. Uh, this is just a general examination, tachycardic, tachypneic, and is requiring a low flow oxygen but maintaining blood pressures. So, what do you think would be the common differential diagnosis before we move on to regional examination or local examination? So, of course, the one of the first differential is still going to be community acquired pneumonia and its causes. However, it's a little subacute for just community acquired pneumonia. Maybe it is a complication associated with community acquired pneumonia. Of course, any subacute or even acute presentation in Indian settings with cough, expectoration, always keep tuberculosis in your differentials. Also, one of the things to keep in mind is melioidosis. Since this is a farmer diabetic presenting with a pulmonary syndrome, it could very well be melioidosis. Always remember, when you're considering TB as one of the differentials, you can consider melioidosis as a differential in presence of risk factors. Other possibilities like fungal pneumonia, of course, we need to have some risk factors, predisposition for things like fungal pneumonia or endemic mycosis. Tropical infections can often get complicated with lung involvement, but more often than not they will have an ARDS kind of a presentation. They will not be subacute. They would be like high grade fever, suddenly the patient is becoming short of breath, having cough, turns out to be ARDS. Other things like septic involvement of the lung from systemic bacteremia. So somebody say has bloodstream infection with staph or Kleb, somebody is having right-sided endocarditis or line-related sepsis, they can have septic emboli to the lung that can lead to similar presentation. So septic embolization per se will not lead to expectoration, but these areas of embolization can break down, become necrotic, and can have expectoration. And of course, you should keep certain non-infectious differentials, although a little less likely in this case with high-grade fever, but then you can have things like vasculitis, anti-GBM syndrome, etc. when the setting is right. Now, on examination, now that we are doing a systemic local examination, right? So you can see a dull note on percussion over interscapular region on the right side, right? Accompanied by a bronchial breath sounds, query amphoric breath sounds. So there's a bronchial breathing and there's an additional characteristic of amphoric breath sounds. There's minimal inspiratory basal crepitations bilaterally, and we examined the oral cavity, which was not looking great. So something like, maybe we are thinking of something in this region. Now, since there is an amphoric breath sound, sometimes it is associated with some cavity formations that may be connected to the airway. So generally, in this kind of a situation, maybe you can think of, a cavity with consolidation. It could be necrotizing pneumonia, it could be lung abscess, it could be tubercular cavity. So all those kind of differentials you can keep in mind. So, like I said, PTB with cavity, lung abscess, necrotizing pneumonia, cavitating pneumonia, septic embolization. So, like I said, so septic embolization, if you see the CT, for example, right? So you can see that there will be peripheral wedge-shaped lesions, and then eventually they can break down and can form into cavitary lesions. So even pulmonary infarcts they can break down and then form into cavitary lesions. But infarcts with cavity formation will not necessarily be associated with infectious syndromes. However, septic embolization followed by cavitation, they are generally associated with an infective component. Other things could be things like empyema with bronchopleural fistula, where also you can have similar findings. So this is chest X-ray of this patient. Here you can see that there is a lesion over here. Now it's a little difficult to characterize, but you can see that looks like a cavity. There is some air fluid level over here, and this is of course from the old surgery. And if you look at the CT scan of the same patient, you can really appreciate this well. These are not all the sections, but one of the sections potentially showed some connection to the airway. So whenever there is a connection to the airway, all those putrid sputum, sour taste, all of that is what the patient will start complaining. So in this case, you can see there is a dense consolidation area with an air fluid level, which is suggestive of a lung abscess. So this patient has come to us with a syndrome, a pulmonary syndrome, which eventually is consistent with a lung abscess. So let's talk about lung abscess a little. So what is lung abscess? It's circumscribed area of pus or necrosis in the pulmonary parenchyma. Now they can either be primary or secondary. Primary lung abscesses result from direct infection of the pulmonary parenchyma. Okay, and most of them will result from aspiration of oral or gastric contents. That's why we should always examine the oral cavity in patients with pneumonia or empyema or lung abscess, just to make sure whether it's an odontogenic infection. They can also arise within an area of pneumonia caused by necrotizing organisms. So, for example, Kleb, Staph aureus, these are known agents to cause necrotizing pneumonia, and those areas can get complicated into development of lung abscess. Secondary lung abscesses occur when there is a predisposing condition. So, a otherwise normal person coming with this kind of syndrome, it's likely a primary lung abscess. But let's say somebody who already has a malignancy, a bronchial obstruction, or hematogenous spread through bloodstream infection, post surgical, impaired host defenses, that is, immunocompromised host, they are called secondary lung abscesses. Now, technically, it's not a lot of difference. However, when you're thinking of primary lung abscesses, as you can see, the differentials will contain mostly, odontogenic infections or staph, Kleb, other necrotizing pneumonia. Whereas when you're thinking of secondary lung abscesses, it could be post-procedural, it could be immunocompromised host. Whenever there's an immunocompromised host, you have to think about fungal infections, atypical infections like nocardia, and then of course you can always think about tuberculosis. Now, if you look at the pathogenesis, now these are not very important, just for basic understanding. It's just the repetition of the same thing. Aspiration is the most common, right? And you check for poor dentition, gingival disease, hematogenous spread, direct extension from adjacent infected space into the lung. For example, empyema spreading into the lung parenchyma, getting complicated as lung abscess, subphrenic abscess, you can cause lower lobe pneumonias and lung abscess formation. Similarly, mediastinal abscess, tracheo or bronchoesophageal fistulas. Bronchial obstruction, very important point, where you have to think of tumors or any endobronchial lesion. So we had a patient recently who had a betel nut associated obstruction of the airway, which got complicated by formation of lung abscess, eventually turned out to be mixed infection, bacterial along with a fungal infection. Similarly, other things that you have to look for is things like super infections or airway spread in existing pathology. For example, pulmonary infarction, congenital malformation. So, congenital pulmonary airway malformation, CPAP. Other things you have to think about is pulmonary sequestration. So, a lot of times, patients with pulmonary sequestration, they'll have a part of the lobe which is not connected to the airway, and that can get infected, leading to non-resolving pneumonia or even bronchiectasis, lung abscess development. So, all of those differentials you have to keep in mind when you're thinking about the origin of the lung abscess. Now, looking at the microbiology. So, even in the previous slides, we have discussed how the classification of lung abscess can help you understand what could be the common microbiological associations or etiology for these cases. So, if it's aspiration, it's most likely gram negative cases, gram negative organisms in 1/3 of the cases, and anaerobes play a very major part. Pneumonia caused by pyogenic bacteria like Staph aureus, Kleb, Pseudomonas, Strep pyogenes, Burkholderia pseudomallei, nocardia. These are very, very important causes. Of course, never miss tuberculosis. So, even if I don't mention TB anywhere in this presentation, always consider that you have to rule out tuberculosis in all your patients who come with a lung abscess or empyema. Because even though gram negatives, etc., are reported to be very common, but tubercular empyemas, tubercular lung abscesses are more common in Indian setting than in the Western setting. Non-bacterial pathogens, we have discussed fungi, mycobacteria, parasites. So, which parasites? Entamoeba, very rarely, Paragonimus, patients coming from Northeast, Echinococcus, important differential, because it won't be a lung abscess per se, but it will look like a lung abscess when it's involving the lung. That is, the hydantic cyst on imaging might be a closed differential. It might look like a lung abscess sometimes. And opportunistic infections, again, the list is long. Think about NTM, Mycobacterium, Nocardia, Aspergillus, Mucor, etc. for your patients with immunocompromising conditions. So this is just a general, overview. Of course, it does not take into account atypical infections, tuberculosis, etc. But you can see that the predominance is anaerobes or mixed aerobes plus anaerobes. The challenge with such cases is difficult to isolate anaerobes. So even if you send a sample, it's very difficult to culture or grow anaerobic bacteria, and therefore generally for all management purposes, unless you're very, very sure, you have to have an antibiotic coverage that takes care of anaerobes as well. Now, if you look at general symptoms and signs in patients with lung abscess, fever with chills, most important presentation, any abscess anywhere in the body, high grade fever with chills is one of the hallmark features. Productive cough, often putrid or sour sputum, especially if it is connected to the airway. Chest pain if pleura is involved, dyspnea, hemoptysis. So all of these can be present. But putrid sputum, copious sputum with high grade fever, think of lung abscess connecting to the airway. Other things like night sweats, weight loss, anorexia, depending on the etiology, uh, duration of symptoms, etc., you might be able to appreciate this. For example, if it's a very acute presentation, you won't be able to, get this kind of history. But if it's a subacute presentation, say immunocompromised person, fungal infection, nocardia, TB, they would have all these features, including weight loss, night sweats, etc. Now, course generally subacute to chronic for most of the causes, but acute fulminant disease is also possible, especially with agents of necrotizing pneumonia and when associated with septic embolization. Imaging findings, these are very typical findings. You may or may not get it on chest x-ray. Better to differentiate on CT chest, but classically you're supposed to see a cavitary lesion with air fluid level. So something like this you will see, which we have already seen in previous images. And what are the typical locations? So it is the dependent regions of the lung. So, aspiration related, when you're thinking of aspiration related, the contents will trickle down to the most dependent part of the lung, which will also depend on the decubitus of the patient, whether the person is, very sick or for some reason is most of the times in supine position, the area of involvement will be different. Whereas somebody who's otherwise walking, talking, they might have a different area of involvement. So, what are the dependent segments of the lung? Superior segment of the lower lobe, posterior segment of the upper lobe, and right middle lobe. So, these are the most important areas where you can see aspiration related lung abscess development. Other patterns, when it is hematogenous spread, of course, what you will see is basically, development on different sites. Not all involved areas might develop into a lung abscess. It could be a multifocal consolidation with one or two of them turning into an abscess. Clinical assessment. So, like we have discussed, can't overemphasize dental disease procedure. Look for aspiration risk. For example, patients in rehab. So, they might have altered consciousness. They might be, most of the times, bedridden, etc., who can have frequent aspirations. Extrapulmonary infection, presence of immunodeficiency, bronchiectasis, these things can help you in identifying or considering the etiological differentials. These things that we have mentioned. Smoking history, of course, is associated with higher risk of development of lung abscesses. And think about vasculitis when you're seeing a cavitary lesion in the lung. Of course, there will be a lot of features for or against lung abscess versus vasculitis related cavity. Sometimes it's very difficult to differentiate, but of course, with careful examination, history taking, and investigations, you can arrive at a diagnosis